This is the practical for an intravenous cannulation. A peripheral cannula we're going to insert into the upper limb. We're going to go into the cephalic vein. Okay, we first of all need to wash our hands because we're going to try to adhere to the aseptic non-touch technique. So for that purpose, we've got ourselves a prepared area. We've opened up a pack and we've got a sterile area to work on. And with the dish came out of the pack. As you can see there with the pack, we've got prepared a 3 to 5 mil saline flush, normal saline, and a 10 mil syringe. That's prepared previously. We've also previously prepared your IV giving set with your fluid bag. Right, first step is to wash our hands before we approach the patient or the equipment. So hands are washed, preferably with soap and water, with gel as a substitute. Okay, so we assemble our equipment. As I mentioned before, we've got our flush. We need to open up our IV cannula and drop that in. It is a 22 gauge, which we always use for training purposes, but you select a cannula to suit your patient's veins, the fluid rate that you want delivering, and the site that you're using. We will need the tourniquet. A disposable tourniquet would be good, but we're using a reusable one in this case. We need a cleansing preparation. We've got Cloricept. You may have to use things like Sterit. So we'll open those and we'll drop those in for use. And we've got our IV cannula dressing. Okay, this is a Tegaderm dressing. So we're going to drop that in and that's ready for use later. Okay, having handled the equipment, we can then approach the patient, and it's useful to gel before you actually carry out your patient's examination. Okay, so patient examination, we actually ask the patient, have they had any experience of cannulation before? If that's the case, then you'd ask the patient whether there is a specific problem that they had or a particular site of vein that is more useful to use than others. And you do an examination as well and form your own opinion on what's a useful site. For this, you'd need to apply a tourniquet around about 2 to 4 inches or 10 centimetres-ish above the insertion site or the proposed insertion site. Okay, you get the vein to fill up by maybe asking the patient to lower their arm, asking the patient to slowly open and close the fist, and by palpating the vein itself and getting it to stand up. Okay. At that stage, you look to clean the site. Okay, so often if the vein has stood up, you may be able to slacken off in order to clean the site, slacken off the tourniquet. If the vein has been difficult to raise, you may have to leave the tourniquet on, but the maximum time that we'd ideally like to leave the tourniquet on would be a minute. Okay, so it's your own judgment. Okay, so I'm taking the Cloricept preparation and I'm breaking the vial. Okay, this is applied in 2 directions and it's applied vigorously, and we clean for 15 to 30 seconds and we will then allow to air dry. The site that you need to prepare will be as big as your cannula dressing. Okay, and it's really important then that we allow it to dry. Okay, at that stage, we put the tourniquet back on tight, and while the site is air drying, we then go and prepare our hands and put our gloves on. In the next phase, we're handling sterile equipment, and consequently, we've prepared our hands, as I mentioned before. We've gelled our hands probably, and we've applied our gloves. Our gloves are clean, they're not sterile, so we should be absolutely watchful about contaminating any of the sterile parts of the cannula or the tip of the syringe. Okay, it's cannula ready for use, and we remove the safety cap, making sure that we've got the bevel of the needle pointing upwards away from the patient. We then draw down, keeping our thumb out of the prepared area, and we approach at a fairly low angle. okay, around about 15 to 20 degrees. And we'll look for a flashback in the primary flashback chamber, which is here. Okay, applying skin traction as we go. Okay, we've got a primary flashback. We drop the angle and advance a further 1 millimeter. We then pull the sharp back and we get a secondary flashback here, and the tourniquet can come off at this stage. Still applying skin traction, we introduce the catheter into the vein. It's very important then that we occlude the vein effectively. And as you can see, I've placed my middle finger on the vein just beyond where this 1-inch catheter lies. I'm also going to steady the existing indwelling cannula by putting thumb pressure on the wings just to hold it steady. Okay. We then take the sharp out and applying good pressure to stop the escape of blood, we take the sharp away and dispose of it and come back with the Lua cap, and the Lua cap is placed on the end of the catheter and screwed to the right until it blocks. Okay, so that's that cannula placed. The next thing we need to do is to confirm that it's actually in the vein, and we do that by applying a flush. If you've got a cannula dressing that has got tapes on, you may actually apply the tape to secure the wings. Now we haven't got that in this case, so I'm going to put the Tegaderm on. This is the Tegaderm dressing. I'm putting this on by taking away the backing paper. And then there's a sticky side which goes down. The clear part is put onto the skin above where the cannula is sited. Okay, so that goes on there like so, and is applied down. Now this is always a little bit tricky, but we take the surrounding tapes off, tear them back. Okay, and we'll retain part of this because on the Tegaderm we've got an area where we can apply the date and time of insertion and the initials of the clinician that sited the cannula, so we'll keep that in our clean area. We then need to flush. Okay, so we lift up the port and we apply a Lua lock or a Lua slip syringe in this case into the port and twist slightly to the right. And then we apply thumb pressure and we find that the cannula will accept this with hardly any resistance. What we see then is the cannula completely cleared of any blood. Okay, and we remove that. That goes to one side, it's clinical waste. And we secure the cap in place. If we want to lock the cap, we actually turn it through 180 degrees. And that's the cannula sited and flushed, and it's patent. When we do the flushing, we are looking for swellings or resistance, which would indicate that we've actually come out of the vein. The next phase is to attach the line itself. Once again, you need to apply digital pressure on the catheter itself, just beyond the tip of the catheter. So we've got our prepared IV fluid. Bring the giving set over. Okay, the cap has been taken off the giving set and we apply digital pressure and just secure the cannula. Okay, we then take the Lua cap off. That's for discarding later, and this slips on and then twists and secures once again with the Lua system to the right. And this is ready for use. Okay, with the IV fluid bag then placed at around about 1 meter above the patient's heart level, we apply the roller valve and we open the cannula to apply the fluid at a chosen rate. Okay, your line can then be secured in a variety of ways. Some people advocate that you'd actually take it round the thumb and loop around. Other people just consider that it should just be looped around. So we'd secure it to the skin. Useful if we can just loop around the line and allow a little bit of clearance off the skin, and that allows for any pull that might be exerted on the line without actually putting pressure on pulling the line or the cannula out. Okay, so we've done that, and that's ready for use now. Okay, so that's our practical. The last thing we need to do then is remove gloves, gel hands, and write up. Okay, so we're going to write up our notes, and we'd also then be in a position to put our sticky on with the date and time of insertion and the initials of the clinician. So I'm going to take that tape off, and this goes just on the edge of the dressing. Okay, good. Thank you.